Dr. Pestieau, it's good to see you. Please go ahead.
Thank you, Marty.
You're welcome.
Thank you for the introduction. And can you hear me?
Yep. I sure can.
Okay, great. So thank you for the introduction and the wonderful opportunity to participate in this fantastic symposium. Let me see how I can move these slides. So here we go. This slide might be familiar to some of you who have visited us. This is a fabulous picture of our Children's National in Washington, D.C. This is where I had the great pleasure of meeting Dr. Eichelberger and working by his side now for almost 10 years. Hard to believe. So here's one of our trauma bays in our emergency room, which at various times of the day quickly fills up with several team members here that are represented in the trauma bay of some ER physicians, surgeons, anesthesiologists, and respiratory therapists, some nurses getting medications ready, and so forth, as we await the arrival of pediatric trauma. So why is an anesthesiologist like me concerned about pediatric trauma? Well, for children older than a year of age, trauma is the leading cause of death in this age group in the United States. Pediatric trauma is also associated with significant morbidity, as you are aware of, and about 100,000 pediatric patients per year are left with some form of disability. Therefore, anesthesiologists like me and many others who are often involved in the initial evaluation and management of the trauma patient should have a clear understanding of differences between the child trauma patient, the pediatric trauma patient, and the adult patient.
Dr. Pestieau?
Yes, sir.
Your slides are not advancing here. There you go. Did you just advance that?
Yeah, I just did, yes.
Because you just went, we didn't see any of the statistics slides. So where are you? On the objective slide?
Here, I'm, hold on, I am right here.
Sophie, okay. Just to let you know, the bottom left corner, just ignore that. That is a delayed view that the audience is seeing, so don't look at that.
Oh, okay. Okay. Thank you, Marty. So just going back here, looking at the pediatric trauma mortality, which follows a trimodal distribution with about 50% of children that are dying at the scene from either fatal head injury or hemorrhage, followed by about 30% of children who will die within hours, either from an airway emergency or a further head injury or hemorrhage. And eventually we have delayed mortality from complication of sepsis, organ failure, or inadequate initial resuscitation. So why does this slide matter? And to me, it really matters right here. For the 30% of children whose deaths are really preventable by rapid identification of problems and early and aggressive therapy. So moving on to a case scenario which unfortunately is not as uncommon in our emergency room here at Children's National is the case of a 5-year-old child pedestrian struck by a car who comes to us unconscious with labored breathing, distended abdomen, and a possible partial amputation of one of his lower extremity. So quickly, as I go through the primary survey, as an anesthesiologist, I worry about the potential impact of the fact that this child is unconscious, has a possible head injury, and how this will impact potential airway management, as I worry about head injury, cervical spine injury and protection, potential pneumothorax or hemothorax from this labored breathing, and as the child might be bleeding out from either a liver lac, a splenic laceration, or this amputation of the lower extremity. We briefly go through the primary survey. I'm not going to go through this in too much detail, but as an anesthesiologist, I really worry right here about A, B, and C, and we'll go over these in just a minute. A quick neuro exam is obviously always helpful prior to further assessment, exposing the child and maintaining ambient temperature, warming up the child as we continue assessing. So as part of the primary survey, an important tool that we use in the acute pediatric trauma care is the Breslow tape, which allows to give us a quick estimate of the weight of the child based on the height measurement right here using this tape. it's a wonderful tool as it allows us to gives us quick indication on the medication dosages, the equipment to be used, as well as the voltage to be used in case of defibrillation and other potential equipment to be used. You see here a cart on this right-hand side, which has medications equipment classified per the color, and each color is basically corresponds to a size of a patient. It's ideally used for children up to 12 years of age, about 80 pounds, which is 36 kilograms. And because of the quick assessment of this weight allows to skip on trying to assess each child on an individual basis. As far as airway management, it is the first priority for an anesthesiologist in managing a child with acute trauma, as the children tend to have a larger head in proportion to their body, as well as a smaller midface. Airway obstruction tends to be a lot more frequent in the pediatric trauma patient than in adults. This, in combination with the increased respiratory rate, increased oxygen consumption, makes the need for obtaining an airway crucial and avoiding further hypoxia. As we proceed with cervical spine precaution, we can do quick maneuvers can relieve airway obstructions such as chin lift, jaw thrust. The insertion of an oral airway, for example, in this child might relieve any type of obstruction as this unconscious child comes into our ER with basically loss of consciousness, which in itself can lead to retropositioning of the tongue and therefore airway obstruction or obstruction by secretions and so forth. Supplemental oxygen is obviously extremely important, either by non-rebreather mask or a bag mask ventilation as we prepare for intubation. As we do ventilate this child with bag mask ventilation, which is a adequate form of ventilation, we want to assess ventilation. We want to look at the chest rise, look at oxygen saturation. We want to feel for midline trachea, feel for potential fractures in this child, feel for crepitus, which might be a sign of a pneumothorax, and listen to the chest for bilateral breath sounds. As far as indications for endotracheal intubation, these are fairly similar to indications in adults, but briefly here, for our particular child, respiratory insufficiency, clearly in this child that comes into our ER, a low Glasgow Coma Scale score, airway protection that we want to definitely move on with, and possibly want to go ahead with transient hyperventilation, as there could be a risk of increased ICP in this child. Now, moving to what might be a new concept to some of the audience is the debate between cuffed versus uncuffed endotracheal tube in children. Well, the debate should finally come to an end, and as was pointed out by two authors in an editorial last year in Anesthesiology, it was clearly stated that there is no longer a feasible role for the use of the uncuffed tube in pediatric anesthesia. That the cuffed tube can now be safely used for pretty much all cases, including pediatric trauma patients, and that are safer and reliably can secure an airway, reducing the need for multiple tube exchanges and increase in the risk of stridor, which we really want to avoid. As far as endotracheal intubation, as we prepare for this, we really don't want to leave this to in sort of an emergency decision. It needs to be done promptly, but also want to be fairly controlled in a fairly controlled setting. We want to make sure, as an anesthesiologist, that we have multiple. Our equipment is ready. We have multiple sizes for blades. Endotracheal tubes, ideally cuffed, like I just pointed out. If we have access to video scopes, such as glide scopes, or the fiber optic bronchoscope can definitely be helpful in certain situations. I also want to mention the supraglottic airway devices, such as the laryngeal mask airway or intubating LMAs, can be life-saving devices in case of difficult to mask patient or difficult to intubate patients. As we proceed towards intubation, the preferred method is oral intubation versus nasal intubation, which can lead to nasal septal trauma, can also lead to increased bleeding from nasal trauma. Confirming tube position is also crucial. It seems obvious to many. However, according to the American Society closed claim study, there was a clear report that 20% of inadequate ventilation came from tube mouth position in acute pediatric trauma patients, as opposed to 9% in adults. So 20% of children were inadequately ventilated due to tube mouth position. So once a child is intubated, checking for tube position and confirming tube position is crucial for adequate resuscitation. This can be done by several methods, whether it's bilateral breath sounds, by confirming CO2 presence via a capnograph or a CO2 detector color change, but also suprasternal cuff palpation is a very accurate method, especially now that it is clear that cuff tubes should be used, and therefore one can clearly and quickly feel for cuff palpation. If one is unable to intubate, call for help and quickly plan for Plan B and possibly a tracheostomy. Again, as we proceed towards intubation, we want to be mindful of potential cervical spine injury. Children with their immature neck muscles and proportionally larger head are at risk for high spinal injuries, and such as pseudosubluxation, subluxation, dislocation. Spinal cord injury without radiologic evidence are also not uncommon, with 30 to 50% of our acute pediatric trauma who may suffer from these. These are injuries in which the CT scan or the radiograph will be negative and therefore will necessitate a diagnosis by MRI. Therefore, in the acute pediatric trauma patient, a spinal injury will need to be presumed until spinal clearance is possible, and therefore wants to proceed with cervical spine immobilization and protection until this can be done. Quickly, these are cervical spine clearance criteria, which you can go back to for reference. As we prepare for induction, we want to be mindful that trauma patients tend to be are considered full stomach. This is because of potential presence of food or liquids, swallowed blood from oral or nasal injury. They also suffer from delayed gastric emptying, and therefore at risk of aspiration, which is why we want to as we proceed with induction, we want to use rapid sequence intubation, which allows for a prophylaxis and prevents regurgitation of all these contents at the time of induction. Sedating and premedication in the acute trauma patient is rarely done. If we want to sedate a child for agitation, we want to be aware that agitation might be a sign of elevated intracranial pressure. It could also be a sign of hypoxia, and therefore one must be mindful prior to sedating the child and look for other causes. Regardless, if we decide to sedate or intubate or induce the child with a sedating agent, one wants to be to proceed to a quick neuro exam prior to doing this in order to gauge the effect of anesthesia and anesthesia and surgery on the child and potential neuro exam. Rapid sequence intubation is how we proceed to intubating trauma patients, and this is how we want to basically optimize our intubating conditions in patients who have a gag reflex. We give them a sedative and a paralytic. We proceed to direct laryngoscopy with manual inline stabilization. You see right here the manual inline stabilization with one provider intubating, another provider doing the manual inline stabilization, and ideally this should be done with cricoid pressure Selig maneuver, which is demonstrated right here, which prevents regurgitation of gastric content. Induction of anesthesia will render the child unconscious, will improve intubating conditions, and also reduce hemodynamic responses. Many agents can be used. Our favorite agent right here at Children's National is etomidate, as it not only has minimal impact on hemodynamics, but is promptly sedates the child. Alternatives are ketamine, propofol, thiopental. We do administer atropine here in all children under 5 years of age in order to prevent a vagal response to succinylcholine. We use succinylcholine as our preferred agent for rapid sequence intubation. It's contraindicated in several conditions, in which case we will basically replace it with rocuronium. So our child here, we would go ahead and proceed with rapid sequence intubation with inline stabilization and cricoid pressure using atropine, etomidate, and succinylcholine. The child will get intubated, will confirm placement, release cricoid pressure only at the time the ET tube is secured. And if the intubation fails, we will therefore call for help. I want to quickly run through this slide right here for vascular access. It's a crucial part of resuscitation, as 39% of deaths are due to exsanguination in pediatric trauma. Only 20% of pediatric trauma arrive in the emergency room with adequate access, and one needs to be mindful of quickly obtaining IV access, whether it's peripheral, central, and if need be, the intraosseous access is also a possibility. Should be done anytime 2 to 3 minutes have elapsed without access. It can be done in any long bone that's uninjured, ideally at the tibia, anteromedial portion below the patella. Any large bore needle can be used. A easy IO needle can be used with it's a little gun that I'm just going to quickly show you right here, which we use and we connect. I don't know if the cam sees me right here. We connect it with a needle to allow for easy IO. It has limited flow and should be connected to a rapid infuser and should be quickly replaced by a more another technique. Quickly here, I'm going to go over our sedation and pain management. Goals of sedation are to mitigate sympathetic stress response, improve physiology, facilitate ventilation as the child is calmed and sedated. Opioids are our first line of analgesics. Many sedatives can also be used, as well as regional anesthesia in the case of limb amputation. Epidurals or peripheral nerve catheters are have great benefits for pain management for the future. Morphine and fentanyl are most popular choices for analgesics, and we use many other sedatives such as benzodiazepine. We're big fans of dexmedetomidine right here at Children's National for sedation, as it tends to provide for stable hemodynamics. So in terms of concepts, to remember that 30% of deaths are preventable, and we should really concentrate on this as first responders. Obtaining an airway in a pediatric trauma patient is crucial, without forgetting our ABCs. Teamwork to get this child through a critical phase is important, while we provide hemodynamic stability and adequate pain control. And some other concepts briefly highlighted here are the supraglottic airway devices, which I mentioned earlier are life-saving maneuvers for difficult bag mask ventilation and difficult intubation. Video laryngoscopes such as GlideScope or here highlighted the CMAC, and the use of simulation to really practice our skills throughout the hospital, so that multiple providers can be at the top of their game when the day comes for critical maneuvers. And this concludes my presentation.
Dr. Pestieau, that was fantastic. Thank you so much. You covered a lot of material in a very short period of time. And a lot of
Yes,
this is...
Thank you. Sorry I went a little over.
No, don't worry. Yeah, it's important. We got to make sure these kids get the right care, so don't you worry at all.
And Sophie, part of the reason we wanted to